physician's clinical judgment. So using artificial intelligence, basically the data has to be fed into this software, and this will give you a prediction model. And it is much better than biomarkers as well. Even in predicting bacterial infection in COVID, it has been found that artificial intelligence can predict bacterial infection in COVID. Basically, what is artificial intelligence? We feed a lot of data from many patients into this model. And then once you feed your patient data into this model, it will give you prediction for your patient. And it looks like that is the way things are moving. It can also predict antimicrobial resistance. So, apart from the clinical data, the microbiological data, the patient's epidemiological data, once that is fed into the software, it will give you prediction of AMR. Not only that, it can also predict antibiotic concentration. So they say there is no need of doing TDMs anymore. Once you put the patient data, that is patient volume status, the positive fluid balance, the creatinine value, it will give you a therapeutic concentration, and it is matched the patient's true therapeutic concentration. So huge potential, especially in our country where we are not doing TDMs, but getting an artificial intelligence should not be a big problem. So data scientist should become an integral part of antibiotic stewardship. And I will finish with this metformin. Metformin as a future of sepsis therapy. Most of our septic patients are hyperglycemic, and they are hyperglycemic because of insulin resistance. And metformin is one of the simple therapy to overcome insulin resistance. And they work through mitochondria. They decrease fatty acid oxidation. There have been previous studies on patients who were on metformin who subsequently developed sepsis. They fare better than patients who are not on metformin. And there is a thought that metformin can cause hyperlactatemia, but they have shown that in spite of whatever is the lactate level, metformin is helpful in sepsis. This was a study done in Pittsburgh where they looked at 14,000 not metformin exposure versus 600 metformin exposure patients. And they found the patients who have been exposed to metformin. It's not a randomized controlled trial, it's just an observational study. The patients who were exposed to metformin at least for a day post-admission, septic patients, they do better than patients who have been. This was propensity matched by various measures, so they are equal by age, gender, severity, diabetic state, HbA1c, and everything. They found metformin to be better than patients who are not on metformin. So looks like even the acute kidney injury was less in these patients, and the composite outcome of renal response was also better. So metformin might be a molecule of future. It might have been, there should be an RCT on metformin in future. And so they did a subgroup analysis. So even in subgroup analysis, it favored metformin of all the classes. So it's a metabolic reprogramming, that's what it does. And continuation of metformin, normally we stop metformin. Basically, if a septic patient comes today, normally we would have stopped metformin. But after this, it looks like that unless we get a robust study, probably there is unless there is a robust reason to stop it, it's better to continue metformin. So today I've covered existing practices. Corticosteroids, use reasonable dose. Think about IgM during the later phase of when patient develops nosocomial infection. Procalcitonin, use it with caution. Multiplex PCR, again, good negative. Stop here. Sorry to take 5 minutes more of your time. Over to our chairpersons.
Sir, you are mute. Subhasis sir, you are mute. Yeah, now listen. Can you hear me?
Yes, sir.
Thank you, Dr. Todi. And I always enjoy chairing Dr. Todi's session because like everyone, we do learn a lot of new things. And honestly, regarding this renin concept, it's very interesting. And but I had some confusion that whether it's a observation related to when you have or you have a down regulation of one receptor, there should be some out-regulation of some factors. So whether that was the cause or it has got some effect on our mortality, response. So that was not clear from that study, but it's a new observation definitely. And second thing regarding metformin, as you have mentioned, that most of our sepsis patient has got lactate high because we do lactate frequently, and we had a long time teaching that metformin can increase your lactate, so we tend to stop metformin. So, but it's a new observation that if you keep just going on with that metformin, probably you can save few more lives. That is new, really interesting. So anybody wants to comment?
Excellent. And no, I don't. I think this is something which is very, very new, and it is good that it is not harming the kidney. Now, Dr. I just wanted to ask one question. Do you believe in phenotypes in sepsis or ARDS, like inflammatory, hypoinflammatory, or ARDS which has a diffuse CT, or ARDS which has a focal CT appearance, and your strategy of ventilation differs? Do you believe in that?
Yeah, there are a lot of studies, especially in artificial intelligence used in septic patients. They have divided into alpha, beta, gamma, delta phenotypes. But the most important point is, how is it going to help my patient, right? If you ask that question, can a certain phenotype help in helping my patient? What they have found now we have to go one step forward. Apart from just classifying as phenotypes, they have found, like this macrophage activation syndrome. If a patient has a phenotype of predominant hepatobiliary dysfunction in sepsis, they would benefit from this IL-1 blocker. The IL-1 blocker in sepsis, the anakinra, was a failed trial because it did not find it helps in sepsis. Then they did a subgroup analysis and they found the phenotype in that sepsis group, which had a predominant hepatobiliary dysfunction and jaundice and high AST/ALT. Those subgroup phenomenally did better with anakinra. So I think that is where the future would go, that we should not stop at just classifying phenotypes and see which phenotype responds to which kind of medications to improve the outcome. Phenotypes are there in everything, ARDS, sepsis, in your COPDs, asthmas, but we need to, as in your asthma, you have diagnosed phenotype and response to therapy as well. The same concept have to come in sepsis.
Which works better.
Very interesting, but we have to stop because we have got a time constraint and other panels. So thank you, Dr. Todi.
Thank you.
Thank you very much. Thank you. Wonderful.
Sir, Doctor. Yes, sir. Sir, Dr. Resu want to ask one question to you, sir.
Yes.
Yes.
Good evening, sir, and good evening, everyone.
Good evening.
Thank you for that enlightening topic, sir. Just wanted to ask Todi, sir, like now, as the metformin thing has been a very new thing for us, for me as well. So now if a septic patient comes, if the patient is on metformin, we should continue, or if the patient is not on metformin, should we restart? Should we start metformin and see the results?
This is an observational data from Pittsburgh. It's too early. But
yes,
it at least gives you a notion that if there is no compelling reason to stop metformin, it is better to continue it.
And then, so the lactate monitoring, how will we judge
metformin, I have never seen metformin causing, though it is there in the books, and it causes type 2 lactate. It doesn't causes lactic acidosis. It causes mainly hyperlactatemia. So that is pretty safe. And in these studies, they have shown that it doesn't cause increased lactate. So lactate should not be a big issue. But, these are observational studies. If one stops metformin, nobody can blame that person. But I think this is the field which we have to look out for. That is where the sepsis update is all about. Otherwise, there is no update. Everything we know.
Yes, sir.
Yes, sir.
Thank you, sir.
Thank you
for very informative lecture.
Thank you.
So we will move to our next session. That session is a panel discussion. There are a lot of guidelines, and also the landmark guideline is the surviving sepsis guideline. But how much we are prepared, because the Indian healthcare sector is scattered, and it's not very structural. Still now, there are corporate hospital or big hospital is trying to make the healthcare system structural, but the rural area or district area, the nursing home, this is not up to the mark. So how this topic is on that that Dr. Sarmili is our eminent moderator today, and she is a senior consultant, Bhubaneswar Apollo, and she is also our zonal ICCM member in national level. And I will request Dr. Sarmili to take over the session and introduce your other faculty, other panelists. Dr. Sarmili, yes.
Thank you, and good evening to one and all. At the outset, I would like to thank you, Dr. Asif, and the organizing team for this opportunity today. And this is an excellent topic, actually, though quite basic and relevant to our day-to-day practice. But many a times when we are in the field by the bedside, patient's bedside, it strikes us like how feasible is it to apply these sepsis guidelines to our Indian patients in the Indian subcontinent. So in this regard, actually, we have an eminent panel of intensivists today with us to discuss. I would like to welcome, first of all, Dr. Ajay Sarkar. He needs no introduction, very senior intensivist and medicine specialist at PLS Hospital, Kolkata. We have also Dr. Shushil Bandopadhyay, as very renowned and reputed intensivist, senior director and consultant critical care at Amri Hospital, Kolkata. We have Dr. Soren Panja. I think he is there. And I would request, yes, Dr. Soren Panja is a very senior consultant, internal medicine and critical care at NH Hospital, Kolkata. I would also welcome Dr. Raja Dhar, if he has joined us. He's senior consultant, pulmonary medicine and critical care at CMRI Hospital, Kolkata, and Dr. Brajendra from Guwahati. He is director intensivist at Health City Hospital, Guwahati. So today we start the session. It will be about not about an academic discussion or session on the management of sepsis and septic shock. Rather, we'll just closely review the relevance and the Indian perspectives. I'd like to share screen, and I'd like to request all the panelists to please keep their videos on during the session. I hope it is visible to all.
Yeah.
Yes.
Okay, great. So this is a broad outline of the discussions. We have 30 minutes. So first of all, I would like to proceed with the introductory statement that the sepsis 3, that is the newest definition we have available since 2016. Now, sepsis 3 is being defined as a life-threatening organ dysfunctions caused by a dysregulated host response to an infection caused by an microorganism. So there are 3 components of it, and organ dysfunctions have been emphasized with a change in the baseline SOFA score from more than equal to 2 from the baseline score. Again, the term which has been thrown into oblivion is severe sepsis. So instead of that, the septic shock has been retained, and it is defined as a patient who has got persistent hypotension, which requires vasopressors to maintain a MAP of more than equal to 65, a lactate level more than 2. And of course, it indicates a higher hospital mortality more than 40%. Now, so my first question will be to Dr. Sushruth Bandyopadhyay about what do you think regarding this applicability of this new definition and relevance of it to Indian scenarios?
The first thing, the argument against, am I audible? I think I'm audible, right?
Yes, you are.
Yeah. The first thing, the argument against the old SIRS criteria is that, if you remember the old SIRS criteria, that it was main tenets were temperature, either abnormal, higher or lower, heart rate, and WBC count, and the respiratory rate. I think that was the criteria on which it was defined. So once they formed the sepsis 3, they were arguing that any two of this could have made a patient having a sepsis, provided he had an underlying infection. That was the idea of the old definition. So they said that basically, suppose a patient just has got a slightly raised blood crystal count, 12,000, and with that maybe just a spike of fever, does it make that the patient is already septic? So does it tell that this patient has got increased mortality? Because our idea is to pick up those patients who has got increased mortality because of this syndrome. It should be an infection. It should be a dysregulated immune response, which of course we cannot prove that way. But third is that we need to show something that it shows that it has got an effect on the patient's mortality. So they argued that if I use just two SIRS criteria, they may not show increased mortality. They may not predict increased mortality. Rather than that, we can use a SOFA score, which has got definite indications to mortality. The advantage of SOFA score per se is that it can be started at any point of time. And you can start off with a baseline SOFA score and do a second SOFA score and show that there is a change in 2 points in the SOFA score and show an increased 10% mortality. So this sounds very logical. That's no.
So you think that sepsis 3 definition is better and more applicable, widely applicable?
Yeah. Suppose I'm telling you a typical scenario. A patient has been admitted, let's say with just a simple fever. He has got a UTI and he has got a 12,000 count and raised temperature. So does it make this patient septic patient? It may not. Just all patients may have a slightly raised count, and he or she has met 2 criteria, SIRS criteria, but he or she may not be sepsis. Then you come into the question of whether it's a mild sepsis or moderate sepsis, which again has been argued against, because if I mean sepsis, I mean something serious. That's the idea, right?
Right. So what do you think about, what do you mean about the Q-SOFA score? What do you think about it? Is it useful?
Q-SOFA is basically, for SOFA score, you need a blood gas. SOFA score, you need a blood gas, you need renal functions, etc. So if you're going to the bedside and trying to diagnose immediately, you may not be having this. And Q-SOFA is very simplified. It's to be applied on the bedside. At the instant you approach the patient, you've got just mental faculty, slight, change in mental faculty, you've got respiratory rate, and you've got a blood pressure, low blood pressure. So any one of them makes a Q-SOFA score of 1. So rather than diagnosing, I feel that this makes the clinician aware that this particular patient might be suffering from sepsis, which needs to be confirmed by, and then you take proper investigation to see whether the patient is actually in sepsis or not. Q-SOFA, when compared with this modified early warning system, it was proven to be less specific. That is the limitation of Q-SOFA. It's a very simple thing, but then it is sensitive and you can pick up that. It makes you aware that this patient might be septic, and then you can prove.
Looks, it is too simplistic and wider sensitivity. I think that when this first it was declared in the Congress, Critical Care Congress in 2016, there were a lot of criticism around also from around the world, and some were published and some were not. And there was also open letter from the Latin American Institute of Sepsis. They also have had reservations about supporting this diagnosis of sepsis 3 definitions, because apparently many of these developing or the MIC or the low middle class or low economy countries were not included in this consensus definitions. And actually, if you look at this Q-SOFA from other perspective, it looks that it might have actually widened the spectrum of suspected cases of sepsis. And countries like India or patients where there is limited health infrastructure, it actually increased the patient burden for the healthcare system. So nevertheless, actually, in the practical scenario, I would like to understand from it's open question, like how many you feel that in the last 5 years that has elapsed since declaration of this new definition, how many centers have actually adopted this QSOFA practices in their hospital or healthcare centers? Dr. Ajay Sarkar, Dr.
Yes.
I think Dr. Rajadhar want to speak something.
Yeah.
Yes.
So what I feel that Susut has explained the new definition, but what we have done with the new definition, we have removed sepsis, because previously we had the classification sepsis, severe sepsis, septic shock, and with multi-organ failure. Now we have removed the sepsis. We start sepsis with severe sepsis, because the criteria for all those 4 or 5 can be with any patient without any sepsis, even with SARS, with infection. That's why the question started with sepsis, means there has to be some organ failure in whatever form. Now, the new sepsis, the new definition, good thing is that you have removed those sepsis, which has got a lot of reservations. But bad thing is that they have made 2 or 3 element of the organ, because it can have any organ involvement. So what I feel that if you have a infection with any organ involvement, you must consider that as sepsis, and then you have to work out in that line. That is my understanding about this sepsis, and I'm sure you will have another sepsis 4, 5 eventually, because it's still we don't know many things about sepsis.
Yeah.
Would you
like to respond?
So yeah, so quick point. So Shushruta, I sort of agree with Dr. Sinha in that I feel that while in tertiary care centers, it's possible to do a SOFA score, to do a longitudinal SOFA score on a repeated basis in a nursing home, in sort of secondary care centers, etc., where plenty of intensive care happens, is actually going to be a challenge. So I think that's one of the problems. So 6 different end organs being monitored on a regular basis by the SOFA score makes it difficult to do in the long term. And I agree with Ajayda in that probably we'll have a more simple score sometime down the line in trying to find out about organ dysfunction. The other point, again, I agree with Dr. Sinha in that the QSOFA score, I think, actually is a very sensitive score. It picks up all patients who might have impending sepsis, but it also increases the burden on the healthcare system a lot in identifying a lot of patients who might not actually become septic and might have a tachypnea or a disorientation or a increased heart rate from some other cause. So I think that's also something which is important to remember. The QSOFA score, I think, is a bit too simplistic, and maybe the SIR score and the QSOFA score are not very different from each other as far as sensitivity and specificity is concerned.
Dr. Sinha, can I make a comment?
Yeah, please.
Yeah, about the monitoring, we are not monitoring, I mean, investigation, we are not monitoring 6 different organ systems. What we need basically is a blood gas, we need a platelet count, a bilirubin, and a renal function. That's all. But this is routinely done. I think right now blood gas is almost universally available. Everybody does a blood gas, and rest of the tests have been already been universal. Everybody does. The question is that whether we want to do this test or we want to limit our this thing by clinical diagnosis by clinical SIRS criteria and see. In that case also we need the WBC count with band forms and all, we need that. So I think the purpose of these 2 are different. One is you're trying to define the sepsis or definitely diagnose the sepsis, and QSOFA is just making you aware that this particular patient may be a candidate for sepsis screening. Otherwise, we could have missed those patients, a slight confusional state. Whatever it does in the hospital, if you're not aware of this QSOFA score, you would just push in a sedative, particularly late in night, and say that this patient is nothing. But it makes you aware that this patient can be going into a fresh sepsis. That is the purpose of the QSOFA score. It is not a definitive, carved in the rock diagnosis.
True, sir. So it has its pros and cons, and I believe 5 years down the line, I do not see wide acceptance of or application of this QSOFA score in the Indian subcontinent, at least. You can correct me if I am wrong. Then we proceed to the next part of this discussion. So this is a case scenario. As a 62-year-old man with diabetes mellitus, hypertension, and history of urethral stricture, is already a known case of that. He had presented with fever, hypotension, with altered sensorium and tachypnea. He had done self-meatal dilatation around 3 days ago at home. No cardiac disease, no. Now his approximate weight is 70 kgs. So my question is for Dr. Ajoy Sarkar. How will you manage initial resuscitation in this case?
From this history, it's clear that this patient has got sepsis, and it also satisfies your Q-SOFA score, 2 out of 3. And obviously resuscitation, we have come across with that resuscitation in 1, 2, 3. Previously, we had a 3 hours, 6 hours. Now everything has been amalgamated into 1 hour resuscitation, and that's very important. We must start with a few things during our resuscitation, or if you call it bundle, that this patient identification that he has got sepsis, then you have to send blood culture 2 sets from 2 different sites, and you have to start the antibiotic at the same time. And since he has got hypotension, that has to be corrected immediately with crystalloid fluid, and the fluid, as it has been mentioned in the guideline, that 30 ml per kg body weight in the first 3 hours. And once you have achieved the or correct the hypotension after giving fluid balance, and then probably you don't have to start any inotropes. But if vasopressors, but if you have still hypotension, and then you have to consider the noradrenaline as a first line of vasopressor. And very important that during taking blood, you must send 1 lactate, and that has to be repeated another lactate, because the resuscitation will be completed by 2 things, your blood pressure and the lactate level. If your lactate level is still high, then possibly you haven't resuscitated the fluid completely. Now we won't go by only blood pressure in this situation. So 2 lactate is important, 2 set of blood culture is important, antibiotic, proper antibiotic, we'll discuss about that later on, and IV fluid, which is crystalloid, always crystalloid, and your inotropes or vasopressor if required. That should be the initial 1 hour resuscitation protocol.
You rightly said about resuscitation. This is definitely a frank case of sepsis, especially with the given history of attempted recent meatal dilatations, most likely neurosepsis. At least as the recommendation says about giving at least 30 mL per kg of crystalloid in the first 3 hours. But many times the situations are not identical. I mean, they are very different. It has to be customized to the patient's conditions. So my question would be for a patient who presents with acute or chronic kidney injuries, patients who have underlying cardiac dysfunctions. Should we be blindly following this? I actually find it difficult to reconcile with the fact that at least 30 ml per kg, supposing this patient is 70 kg, fluid must be, is it necessary to be given to all patients? Should we be following it?
That's true, because when you are giving fluid, it's at the same time you have to assess the fluid status of that patient. So we do go by fluid assessment as well. And if you find that patient is already fluid overloaded, like in CKD patient who had an acute kidney injury but still in fluid overload, then you have to restrict your fluid. Or a patient who has got a bad cardiac status, say cardiomyopathy, whose ejection fraction is very low. So in my opinion, and I'm sure every good unit has got an ultrasound machine. So whenever you are pushing fluid, you must see the IVC status, you must see the contraction, left ventricular contraction. And if you find that patient is in fluid depleted state, you have to give that amount of fluid. But if the patient has got already fluid overloaded state, then you have to give slowly fluid depending on his blood pressure, as well as you need to consider before pushing that amount of fluid, the vasopressor first.
Right, sir. So one size does not fit all. And as you mentioned, that ideally we should be assessing their fluid status, and preferably with an ultrasound. That is, the question arises in an Indian subcontinent, in an Indian context. Is it possible to have that kind of advanced monitoring in all emergency departments or even in the intensive care units, though that is the most ideal and recommended these days? So following it universally, I have some reservations about it, and I believe such statements should have a connotations. Like you can give it, maybe rephrase the statements as to be given in small aliquots or small boluses and reassess. because that will actually, because many times if you could have listened to the students during examinations in our Indian context, many times they just blindly would pronounce that I would like to give 20 to 30 ml per kg of fluid. So where there I find problem, because later on these patients tend to have more fluid overload than not. And this leads to actually further organ dysfunctions and where we advocate for de-resuscitations. So my next question is about hemodynamic monitoring. Dr. Soren Panja, is he there with us? So
yeah. Yes,
this patient has been given, as Dr. Ajay Sarkar recommended, that has been given 2 liters of crystalloids and needs vasopressor support now to maintain his blood pressures. So now what all hemodynamic monitors would you like to use for this patient?
Regarding the monitoring, we know right now there are the concept that there are static monitoring or dynamic monitoring. As we know, there are some earlier we used to put on, say, sometimes central line, then there are arterial lines as well as. So those are the static monitoring earlier we used to do, but there are certain limitations for those things, but still it is the most commonest we can use it. So pulse, blood pressure, or sometimes urine output, as well as if possible an arterial monitor. These are the basic things comes in the category of the static monitoring. In spite of the limitations, these are the initially we can do it, and it can be easily available in most of our situations. And other than that, there are for the dynamic monitoring. So there are defined things in terms of the fluid, whether the patient may require fluid or may not require fluid. So there are defined, if the patient is having some arterial line, we can look for some systolic pressure variation, then pulse pressure variation, or sometimes the stroke volume variation. But this needs actually some kind of software in our monitoring system. And that sometimes in our hospital, because it is in our context, so our means not in my context only. If we think about the Indian scenario with some secondary as well as tertiary, so some areas may not be available with this type of system. But from the graphics also, sometimes we can judge and guess. Other than that, sometimes also we can, in a bedside, we can also monitor sometimes the passive leg raising test. So during that time, once we are elevating both the lower limbs of the patient or both the legs, so that time also there should be the ultrasonography machine that should be there. So with that, ideally we should monitor the cardiac output. So that type of thing should be there. Along with that, there are other calibrated, non-calibrated system. So some relatively most of the tertiary care hospital, they might have 1 or 2 defined type of monitoring. So non-calibrated system, there are flow track or sometimes non-calibrated system like PICO, LITCO. So these may not be easily available. But I think right now most of the centers is having ultrasonography machine. So that's why with the ultrasonography machine, we can easily judge the inferior vena cava diameter. And sometimes if the patient is on ventilator, then collapsibility, distensibility, as well as the superior vena cava diameter that can be judged. Along with that, if we have that software that can be monitored, the monitoring of the cardiac output, that monitoring can be done. And sometimes also if the patient is on ventilator, the end expiratory occlusion pressure that can also, we can monitor it. So these are some of the monitors depending on the center where we are using, from the non-invasive to invasive to different type of static and so we could use the combination.
Thank you, Dr. Soren. Actually, that was a good summary of all the hemodynamic monitors that can be utilized for these patients either in the emergency or ICU. But all these modalities of this advanced monitoring got challenged in the time of COVID, when the patients, and this is the recent guidelines about COVID and shock in 2020 from this same Surviving Sepsis campaign team, that they confine mostly the recommendations to capillary refill time, serum lactate measurements, and bedside clinical assessment of urine output. Urine output is often known as cardiac output for a poor patient. So because this advanced monitoring, which you talk about, this ultrasound or assessment of the cardiac parameters to judge the fluid responsiveness, All this, for obvious reasons, could not be practiced or recommended widely to be used in COVID units when the patient present with shock. So that is why we need to have knowledge of both the clinical assessment and the advanced monitors at the same time. But as you rightly said, that in Indian context, availability of this ultrasound machine, availability of the skilled personnel to use, and its interpretation, these are in themselves are also challenges. So we'll come to hemodynamic targets. Now this patient is has got fluid, is on vasopressors. He had got some hemodynamic monitoring set in for him. I'd like to understand from Dr. Rajadhar about what kind of hemodynamic targets would you like to set for this patient?
Thanks. Just wanted to add to your previous statement about COVID. I think a lot of the statements made in the revised guidelines for COVID were actually more from beds getting inundated, lots of patients, not enough manpower, rather than scientific reasoning. I think that is something probably that we should take into consideration when we go forward in this so-called non-COVID world, hopefully. So I think Shorinda spoke very nicely about the hemodynamic monitoring. So I'll put it simplistically and in brief. I think when you're looking at blood pressure, you're looking at a mean arterial pressure of somewhere above 65 or 70. So 65 is what's recommended, and you might want to have it above 70 as mean arterial pressure. You can also monitor the systolic blood pressure. We have spoken about other parameters of hemodynamic monitoring, invasive parameters of hemodynamic monitoring a little while ago, and I think it's probably not beneficial to repeat them again. As far as clinical and biochemical parameters are concerned, I think Dr. Todi spoke very nicely about procalcitonin. I'll repeat it once more because he's been thorough. So procalcitonin, I think, is a very useful tool in de-escalating antibiotics. It's useful in cutting down the duration of antibiotic therapy. There's one study from about 7 years ago, which I recall, where the absolute value of procalcitonin, which was quoted as being above 2, has a separate higher risk for mortality while the patient is on treatment. However, there are other studies which have shown escalating antibiotics or changing antibiotics just on the basis of procalcitonin will have its demerits. So procalcitonin mainly for de-escalation rather than escalation. Dr. Sharkar spoke a little while ago about lactate. I think lactate is an excellent marker of tissue hypoperfusion, and hence lactate levels which come on an ABG is something that can be easily monitored to make sure that tissue perfusion has been restored adequately when you're trying to make sure that the patient is rehydrated on an adequate basis. You spoke about urine output. So I'm sort of going back to clinical parameters again. You spoke a little while ago about urine output, and I think that's very, very important that urine output be monitored along with the blood pressure. And again, you made a very important point on the slide in front of me. Important to know whether the patient is a known hypertensive, what antihypertensive medications that patient takes, and the blood pressure and the MAP that you aim for, to an extent, also needs to be balanced on the basis of whether the patient is a pre-existing hypertensive on medications or not. Other factors like chronic kidney disease, liver disease, etc., also needs to be taken into account.
True. So most of this chronic hypertensives, actually, these are a subgroup of patients who definitely need to aim for a higher MAP for end organ perfusions, and not to forget the other extreme of patients who are chronically vasodilated states like chronic liver disease. Many times, we witness patients who have a blood pressure of 90/50, but the patient is perfusing well. So at the end of the day, it is the end organ perfusion and just a number like a MAP which should be treated. And normalizing lactate, obviously we chase lactate during resuscitations and treatments, but lactate, as we heard Dr. Todi also talking about hyperlactatemia, which might be caused during the treatment of patients who have been on metformin, or if we are going to use metformin for these patients. So actually it has also got its own fallacies. So those limitations or those exclusive group of patients also we have to keep in mind. And some of the centers I have also noticed that they use low dose adrenaline as well to maintain the blood pressure if NORAD is particularly not working. And these group of patients actually can have about moderately high level of lactate. So these are the limitations of lactate. So my next question will be to Dr. Brajendra about cultures. It is highly recommended in the surviving sepsis guidelines. So for this particular patient, what all cultures would you like to send and how fast? What all cultures would you like to send for this patient? I think you are muted. Dr. Brajendra, you are muted, I think. Yeah. We can't hear you. We can't hear you.
Dr. Brajendra, you don't have a headphone plugged in by any chance, do you?
Yeah, please remove it then.
Yeah. Am I audible now?
Yeah.
Yeah. Sorry, Dr. Sarmili, I was on the way. Anyway, just two comment before I start my point. One is we are discussing about sepsis in a hospital, in big hospital. We are excluding almost 60% of the rural hospitals where probably lactate will not be measured as a bundle, where probably there is no microbiologist with a microbiological data to get. Okay, and quick SOFA may be very, very important in a ward, not in ICU. And if we make SOFA score, it will be used only in ICU probably. So we are excluding many septic patients outside ICU if we use only SOFA to diagnose sepsis. This is just an opening comment. That's why culture, if we speak about culture, probably we'll be speaking on those patients where probably there's a microbiology department where microbiologist is also there, so that they can take a culture urgently within as fast as possible, because the time limit is very, very short, as soon as possible, less than 45 minutes, because we'll have to give the antibiotic before 1 hour. So that you should take a paired culture, 2 sets of culture, both aerobic and anaerobic, and we're supposed to see the urine culture also here, urine routine examinations and urine culture, including probably fungal sepsis, fungal culture also should be sending. And fast means it should be as early as possible. The fast culture should be taken as early as possible. Should be feasible within 45 minutes. But if it is delayed, many a time the technicians may not come. Many a time the ready-made culture tubes may not be available. So in that case, probably we'll omit those things. And that happens in probably more than 60% of cases.
Yeah. Do you think like asking for this cultures actually delays administration of antibiotics in the Indian context? Because
many a center, if you are discussing about Indian context, probably if you see almost 60, more than 60, around 62% of the hospitals are rural hospitals without having a microbiologist and no microbiology department. There, they will not even think about sending a culture. In those situations, probably if you are discussing about Indian context, the first dose of antibiotic will be more important than sending the culture, because the culture will be going to a collection center. Maybe that will be plated. That actually delays the antibiotic injection.
That's
but again,
pertinent point.
Yeah.
But that doesn't mean that we should not be asking to send cultures. The point to be kept in mind that actually if you're asking your paramedic staff to collect culture and then give the antibiotics, many times actually the administration of antibiotic itself gets delayed, and up to maybe 3 hours, 4 hours, patient may not have got the first dose. So that's where the misery and the fallacy lies. So
yes.
And many times I wonder, like we are insistent that take the cultures and then give the antibiotics. But actually, as you said, we just discussed that it should not be so that even if the patient has, yes, I understand if you have given the antibiotic and drawing cultures later on, the chances of my positive microbiology isolations goes down, but it is not becomes zero. So nevertheless, I think that let the patient have the advantage of having the first dose, and later on, as you know, circumstances are favorable, the appropriate cultures can be done for these patients. And as you rightly
Dr. Sharmila, we have very
yes, we'll take 10 minutes because I think we started a bit late. Yeah.
And also Dr. Rajadhar is in a hurry. So
okay.
Please.
So I think we can allow Dr. Sharmila to speak, because most of my part, she's also taking care of that. So please go ahead.
So I'll try not overlap your parts. Okay, my next question will be to Dr. Shushruth about what kind of antibiotics would you like to choose for this patient? He is on vasopressors now, and most likely a suspected urosepsis. Dr. Shushruth.
Yeah, am I audible?
Yes.
So basically the question, I'm just, the time is short, I'm directly going to the question that when we should use PENEMs, when you should settle for BL-BLI combinations, when you should think something different. Basically, the PENEMs are till now the mainstay if the patient is community-acquired infections and they does not have any exposure to PENEMs before. then we say if provided the patient is in shock. If the patient is not in shock, not in imminent danger of death, we may allow BL-BLI combinations. The reasons, I'm not going into the details. If you ask me, I'll discuss them. And if the patient has got a chance of a hospital-acquired infection or already exposed to PNMs, then you need to change. If it is a urinary tract infection, possibly you need to go for colistin. If it is a lung infection, possibly you need to go for poly-B. So depending on the hospital flora, I think you need to do that way in a septic shock patient.
So why actually, you said that patient, if the patient is in shock, would like to go for carbapenems and not the broad spectrum carbapenems?
Yeah, there are two issues. One is, as you know, I mean, there are three actually points in favor of penems. One is that some of these community-acquired infections in our country may be MCs, which are resistant to BL-BLIs. Next, the BL-BLIs have got a thing called an inoculum effect. If the infection is overwhelming, their BLI part may be spent, and then they become just BLs, and the beta-lactams, and then they become ineffective. And third, if you remember a large Australian trial which showed that even in sensitive organisms, penems are a lesser mortality than BL-BLIs. So the point is that if you feel the patient is in, the idea of this empiric antibiotic broad spectrum is that we don't want to take any chance. We want to cover everything. When the patient is in imminent, we cannot, of course, cover everything, but we make a general clinical diagnosis and then go. But we should not take any chance that there should not be any MCs which are missed. There should not be any inoculum effect and the patient dies because of that. So if we feel that the patient is in septic shock and has got a 6% increased mortality with 1 hour delay in appropriate antibiotics, I want to give my first antibiotic appropriate. In that case, if it is a community acquired, my preference is still penems, unless you are suspecting a site of infection where it may not be a gram negative. Or in that case, you can add another gram positive coverage with this. And if it is a person who is already exposed to penems or is a hospital-acquired infections, I think hospital-acquired infection, most of the hospitals in India, 50-40% of the infections are penem resistant. In that case, we might go for something else.
Right, sir. I think that's why it is a wise, judicious, practice. Actually, one has to be very wise in differentiating such risk factors. And somewhere or other, this kind of probably it has led to a wider abuse of the higher end antibiotics, mainly the carbapenems, even in the smaller peripheries. As Dr. Bajendra was mentioning, 65% of the hospitals are in the rural setups, and probably we see here and there everywhere carbapenems are being used widely and freely.
If I can interrupt you for just a moment, I may short, but then basically they are not, penems are misused not because of this, not because when they're used in septic shock patient. Unfortunately, penems are used not for septic shock, they are used for everything. They're used for just 20,000 blood count without any septic shock. They're used when even the infection has not been proven. I mean, recently a company has named their meropenem as meromust. That means the practice is something like that, I must give a meropenem before the patient dies, even if the patient dies of cardiogenic shock, the patient gets a meropenem. So that is the practice which is killing us.
So after initiation and maintenance comes the stage of de-escalation practices. So I would like to ask Dr. Soren about how do you like to de-escalate antibiotics in his practice for his patients? Dr. Soren.
Yeah. Dr. Sormila, regarding the de-escalation practice, the first and foremost thing is that definitely there should be a kind of clinical response from the patient side. And particularly the patient should be without any fever. If the patient is on shock, the shock stage should be recovered. Patient should not be on any particular vasopressor agent. Along with that, once we are getting the final culture report, by the time in 48 to 72 hours, so whatever method we are following, if we are getting the culture, then we can also streamline our antibiotics depending on the result of the culture sensitivity report. Along with that, we should also sometimes regarding it is about the change of the antibiotics from the higher antibiotics, like as we are discussing from the carbapenem to other group of antibiotics. Along with that, there are also about the duration of the antibiotics. That duration also in biochemical terms, we can see some of the biochemical markers are already we are discussing about the O-calcitonin. And in some places, if not available, then C-reactive protein can also be used in place of that. So these are the some of the EA, and also the level of the your procalcitonin level. So it should be less than 80% of the baseline, or sometimes it is less than 1 in some of the references. So that can be used as when we can actually stop the antibiotics. So this is some of the points what we can suggest.
Right. So you said you will combine it both on your clinical assessment and biomarkers whenever possible.
Yeah.
So regarding
clinical assessment, result of the culture sensitivity report as well as the biomarkers, all we should take together, and then we should take a decision.
Right. So regarding the indications for biomarkers, I would like to ask Dr. Rajendra about in what kind of septic patients or septic shock patients or patients with sepsis would you like to ask order for biomarkers? Because again, it is expensive investigations and not available in most of the hospitals which treat such patients. So in which case of patient?
Dr. Sinha, Dr. Sinha, I'll just take your leave. I'm sorry, I'll have to leave. I've got a round, so very, very sorry, but enjoyed that. Please continue, and I'm sorry to have interrupted.
Yeah, we'd miss you, Dr. Raj.
Okay, regarding biomarkers, actually the cheapest biomarkers is CRP, but most of the people, for bacterial sepsis, actually, if suspected bacterial sepsis, procalcitonin has been used extensively. But procalcitonin is not the only marker. Only tell you that the initiation of antibiotic will not be decided upon the procalcitonin level, as already discussed by Dr. Todi sir. But the de-escalation part, if you see the de-escalation part, if procalcitonin drops down 80 log from the beginning, and then probably, or it becomes negative after clinical resolution, probably on day 5, or the decision to continue antibiotic will be decided upon, or de-escalation may be decided upon on that. But again, the cutoff value is also important, initial cutoff value. It has not decided whether this is 0.1 or 0.25 or that's why. So
in the COVID times, actually, when the immunosuppressants like Toci or the high dose steroids were being used, there were a lot of
lot of conditions where it may be falsely high also. Even pancreatitis, trauma, then a lot of other conditions, burn, then procalcitonin may be falsely high. So it will not be helpful in that situation. Even in pregnancy also.
So coming to choosing the fluids about crystalloids versus colloids and balanced salt solutions versus normal saline. So I would like to ask the panelists, Dr. Ajay Sarkar and Dr. Soren, what kind of fluids would you use? If you have to choose between, obviously there is a consensus that crystalloids are better than colloids in resuscitations and even during maintenance if required. But if you have to choose normal saline versus balanced salt solutions, which one would you prefer? Dr. Ajay Sarkar?
Regarding your fluid, if you are giving for resuscitation of shock patient only, then crystalloid is fine. And that can be normal saline as well, because you are not giving more than 3 liters. But if you are resuscitating a patient with shock secondary to injury or trauma or even diabetic decay patient, then I would go for balanced solution, because you need to give more than 3 liters saline. In that case, because of excess amount of chloride, you can get some hyperchloremic acidosis in that situation. So my choice of fluid will be depending on how much I'm going to give in that patient. If it is less than 3 liters, probably normal saline is okay. And again, the colloid, I don't find any reason to consider colloid in any cases unless you are giving a lot of fluid and you are having problem with fluid overload. Then in that case, the 5% albumin is a better option, but we are still getting 5% albumin. But it's not easily available all the time in my hospital at least. So always I'm using saline and balanced solution in a situation where you are contemplating that your fluid volume will be more than 2.5 to 3 liters, probably to avoid hyperchloremic acidosis. And somebody might say that chloride can cause kidney injury as well. So that's the thing you can avoid by using balanced.
Do you agree with Dr. Ajay Sarkar?
Yes. What
Dr. Soren. Yeah. Dr. Soren.
I fully agree with Dr. Sarkar. I don't want to prolong it. Already we are running short. I think Dr. Sarkar is absolutely, he's right. Both the crystalloid, initially as resuscitation, we should use the crystalloid solution and solve versus here, because we are using right now not the liberal, rather conservative fluid approach. So in that regard, there is no difference between the salt normal saline solution versus any balanced salt solution.
Right.
So
the hypochlorous remains a concern with over-resuscitation with normal saline and their propensity for acute kidney injuries. Regarding usage of vasoactive medications, noradrenaline remains the first choice for the septic shock patient. What about in an Indian continent? We still continue to see usage of dopamine for patients who have been shocked. So in that context, I would like to ask Dr. Sushruth about what are the cases of septic shock? Where would you at all consider dopamine as an alternative vasopressor agent or not?
Basically, the idea that norepinephrine is better than dopamine is from, I think, from the SOAP observational trial, that is the European Registry of Septic Patients, where it was seen that dopamine causes more cardiac arrhythmias, and particularly in patients with who have got cardiac diseases. So that way, right now, our practice is that dopamine has become almost a no-no. Nobody wants to use dopamine at least as the first line. Everybody uses norepinephrine. The main problem with norepinephrine is it's costly. When you give it in a higher dose, it can cost you a few $1,000s a day. So if you find that you are working in a place where it is, how do you call it, resource limited, then you can jolly well choose a dopamine if you feel the patient does not have much cardiac problems. Underlying young patient, not coronary artery disease, there you can jolly well use dopamine as a vasopressor, not as a renal protective.
We also see your recommendations, though it's a weak category, about using dobutamine in patients who show evidence of persistent hypoperfusion despite adequate fluid and use of vasopressor agents. So this is a very important point I would like to discuss, because many times patients who are actually in shock, if you're adding dobutamine, they tend to further drop their blood pressure. It actually rather compounds the problem of hypotension and also gives rise to tachycardia. So this one, something I would really have reasoned about recommending this to my team. So what is your take on that, Dr. Sushruth?
Dobutamine.
Yeah,
dobutamine,
in a patient,
the idea dobutamine is not to be used for, say hypotension. The idea of dobutamine is that it needs to increase the cardiac output. That is the idea, that if you feel that the cardiac output is not maintained, ultimately not as per expected, then you can always use dobutamine. That was in many reverse trial, and also afterwards, if you feel that the cardiac output is not adequate, dobutamine can be added. But see, as we already pointed out, secure your blood pressure first. It's an inodilator. In a patient with a borderline blood pressure, if you use dobutamine as the first line and the patient is not well filled, the patient may suddenly go into a severe shock. So that is the problem with dobutamine. Always secure with the norepinephrine or something like that, and then use the dobutamine. You can use it to increase the cardiac output. That is fine. Ideally, we should check the systemic vascular resistance and decide, and cardiac output, and decide on our agents, but I don't think that is practically possible.
Right. So the Indian subcontinent, the unique challenges that are left with us are there are many septic mimic conditions. I think Dr. Resha is going to cover it in her next sessions. Mostly those are the tropical fevers, dengue shock syndromes, who may not have a bacterial sepsis, and late reference. Patient might be, already suffering in the illness at home, and very lately they present to a proper hospital, or maybe a primary to secondary and then to tertiary hospitals. And the extreme heterogeneity of the healthcare infrastructures. I'd like to quote one survey that was conducted by KPMG in the year 2015, where it was found that 85% of the healthcare services were rendered by private healthcare setups. So that is a striking figure. I wish it has changed by now in 6 years. And compliance in adherence to protocol. This remains a big issue, even in big corporate hospitals, even bigger teaching tertiary hospitals. Compliance to adherence to the protocols for sepsis, it still remains, not far from ideal most of the cases. So I'd like to, it's an open question, I'd like to hear comments from the panelist, Dr. Ajay Sarkar. Do you agree with this, or anything you'd like to add?
I fully agree with your comment about this, because these are the situations where, every patient is different, and medicine, the knowledge, science is the knowledge, but the practice of medicine varies from patient to patient, also varies from disease to disease. So I fully agree that in these situations, we need to apply your own judgment, addressing their problem in different angles. That's my perception. Regarding can I comment one thing about this de-escalation? Just one comment, because what I find that it doesn't mean that you have a blood report there saying that BLBLI is sensitive and you have been on carbapenem, so you change over to BLBLI. It all depends on the nature of the infection. If you find that your infection needs 2 weeks or prolonged treatment, then probably, because most of us are getting that reports during 4th, 5th, 6th days, the culture report. And even with backtech culture, the first day they will say that something is growing. Second day they will confirm, and the sensitivity pattern we are receiving on after 48 hours. So by that time, patient has got some improvement with the drugs. So for a pneumonia, you don't have to give more than 7 days treatment if it is just pneumonia, unless there is any empyema or abscess or anything like that. So I find that if you have gram-positive infection, then you must change, and because gram-positive has to be given at least 2 weeks, or if it is pseudomonai, you have to give at least 2 weeks or 10 days. That is my perception about de-escalation.
So most of us agree that it is the early identification, good resuscitations, and it has to be customized to the patient's profiles, because one size won't fit all. And de-escalation as appropriate time still remains a challenge. And in one of the pilot studies in our center in 2014, we found that de-escalation was only happening properly, if we go according to the recommendations, only in 16% of cases, 16% of cases. It has changed thereafter. So still there is scope for improvement in this scenarios. And one consistent observation is about this surviving sepsis guidelines 2016, that most of these recommendations are weak and based on low quality data, and few of them are actually best practice statements. And if you're a believer of evidence-based medicines, is one of the most widely followed and discussed guidelines in the world in the field of critical care medicines. But if you see take a close look at this, these are mostly weak recommendations and low quality data. So I think it is time for revision of this guidelines, and maybe in the Indian subcontinent, because we have such a variety of patients and disease spectrums, we might come out with our own sepsis guidelines. And at the end of the day, it's a clinical assessment and judgment which should stand superior to all the recommendations and blood tests and imaging. Thank you very much, all the panelists.
Can I make a comment?
Thank you.
Can I make a comment, please? Just one comment. Because I wanted to say that, because we have been discussing about surviving sepsis guideline, but I want to just mention one thing. There is another thing like sepsis management in resource poor situations, which is actually endorsed by European Society of Intensive Care Medicine, and published in 2019. It's extremely good book. Probably why dopamine is being used in resource constraint situation. How you can use vasopressors without using a central line, which is very, very prevalent in peripheral hospitals, maybe in the village hospitals. I think we should be having more time discussing in those situations, where in resource poor situations probably we will be using those kind of innovations, and these are guidelines, in fact. Thank you very much.
Thank you, sir. Thank you, Dr. Sarmila, for this wonderful session, and thank you all panelists. We will move to our next session. Next session is the little bit controversial session, whether we should follow this guideline to all patients or not, because already Dr. Sarmila raised this question. There are few things are sepsis mimic, those that are not proper sepsis. And for this session, our moderator is Dr. Rishu Gupta. He's from Guwahati, and he's a senior consultant and HOD in the Department of Critical Care Medicine in CT Hospital, Guwahati. So I will request Dr. Rishu to introduce your panelist, and please continue the session.
Okay, thank you so much, Dr. Asif. So I won't take much time because already we are far behind time. And thank you, Dr. Sharmili, for making my half of the job done. So we have been discussing about sepsis and about sepsis guidelines and what to do, what not to do. So today in this panel discussion, we will be discussing where we should not follow the sepsis guideline, or where do sepsis guidelines can be followed or is used for all the patients or not. So to discuss this, we have amongst us an esteemed group of panelists. We have Dr. Mohit Kharbanda, who is the Director of Critical Care Medicine in Desun Hospital. Welcome, Dr. Mohit. Then we have Dr. Chandrashish Chakravarti. He is a Senior Consultant in the Department of Critical Care Medicine and Polo Clinicals, Kolkata. Welcome, Dr. Chakravarti. Dr. Shantanu Das, he is the Head of the Department of Pulmonary and Critical Care Medicine in Mission Hospital, Durgapur. Dr. Saurav Kole, Senior Consultant in Critical Care Medicine at the Bellevue Clinic. And Dr. Aviral Roy, he is basically from Internal Medicine and Critical Care Medicine. He is the Director of Department of Emergency Medicine from Medica Super Specialty, Kolkata. So as Dr. Sharmili had been mentioning about the sepsis mimics, so that's why the definition have evolved from 2001 to 2016, because many of the conditions they mimic sepsis by meeting the criteria of SIRS. So these include pulmonary embolism, adrenal insufficiency, diabetic ketoacidosis, pancreatitis, anaphylaxis, bowel obstruction, etc., which is not sepsis. These are conditions which mimic sepsis. So as I've already stated, so now should we use or follow sepsis guidelines for all patients? Where do we not follow? So I'll just put few case scenarios so that it becomes easier for us to recollect and to know and to proceed. So this is a case scenario, 61-year-old male, known hypertension, a known history of diabetic, known hypertension, end-stage renal disease on maintenance dialysis, known dilated cardiomyopathy with a low ejection fraction of around 30%, complaint with medications, and comes to the emergency room with fever for 2 days, increased weakness, lethargy for 2 days, confusion, disorientation, which started on the day of admission. His vitals, he was having a low blood pressure, a tachycardia of 120 per minute. He was febrile, he was tachypneic, and was maintaining a saturation of 96% on room air. There was redness and swelling at the AV testicular site. Lactates were high at 4.8, and AVG showed acidosis, which probably was metabolic acidosis. Chest X-ray shows clear lungs. So please remember the case. We'll be discussing this in a subsequent discussion. Another case, we have a 22-year-old healthy male presented with fever, as we are seeing in this COVID pandemic. So that's why I just have put up this case with fever, profuse sweating, and passage of blue still since 5 days, vomiting 2 days. He had recent history of travel, was not on regular medication, no allergic history, had no preceding respiratory symptoms. He was hemodynamically unstable, though his respiratory he was maintaining on 4 liters of oxygen by mask. There were skin rashes and petechiae over the chest limbs with conjunctival congestion. Anti-SARS-CoV-2 antibody was positive. All cultures were negative. CT scan showed minimal bibacillar infiltrates with septum thickening. So my first question is to Dr. Chandrashish, that regarding sepsis and COVID, do you think that we follow the guidelines, all the guidelines in sepsis with COVID? Dr. Chandrashish.
Yeah, hi.
Hi.
So first of all, thank you for inviting me to this talk. There is before going into COVID, I just wanted to say that we are venturing into something that is viral sepsis. And viral sepsis, the understanding of viral sepsis is slightly different from bacterial sepsis, which is when we say sepsis and septic shock, we usually mean bacterial sepsis. Now, if I, for just for a few seconds, if I can go to the pathogenesis, when we, the viral sepsis basically is mediated through the, like any other sepsis, it's mediated through the PAMPs and DAMPs, that is the pathogen-associated molecular patterns and the disease or the damage-associated molecular patterns. And in bacterial sepsis, the inflammasomes usually will trigger, or the macrophages will usually trigger a response through the IL-6 pathway. And then it will release further cascade of chemokines and cytokines. And we usually use CRP as one of the biomarkers to look at the inflammatory response of the inflammatory cascade. On the contrary, when we look at viral infections, if whether it is COVID, whether it is dengue, other hemorrhagic fevers, etc., the pathogen-associated molecular patterns, usually through the inflammasomes and macrophages, will activate a different pathway, interleukin-18 kind of a pathway. And although it can also increase IL-6, but the IL-6 increase is much less. Although there's a lot of hype in COVID-19 about IL-6, what is it called, wave cytokine storms, but usually in IL-6 we do not get storms in case of viral infections. We get a very mild increase of IL-6 in the range of hundreds, 36, 48, 60, 100, 200, like that. If you compare it with bacterial infections, the IL-6 goes up in the range of thousands. And then it basically triggers a response through an increase in ferritin. So ferritin goes much higher in viral infections. CRP goes much higher in bacterial infections along with IL-6. Although also procal goes much higher in bacterial infections. So when we find high ferritin corresponding to slightly low CRP, a lowish IL-6, procal either normal or lowish, we find that this is going towards viral sepsis. And when we find a mixture, then there can be a viral sepsis with secondary bacterial infection. This is the first thing which we need to differentiate. Now, this child, who you're talking about, has presented with rash, petechiae, fever, profuse sweating, and it looks like it's one of the variants of viral sepsis where the patient is presenting with both respiratory distress as well as systemic symptoms. Now, why is it happening? So these kind of viral infections, the primary pathogenesis of viral infections after the mechanism is that it is going to affect the endothelial junctions in the blood vessels. So the endothelial junctions are attached with adherence proteins, with glycocalyx, and with the help of tight junctions. Now the viral mediators are going to break this tight junction and make the vascular endothelium extremely permeable. That leads to extravasation of fluid outside the vasculature and relative volume insufficiency. We have seen this in dengue, and it does happen in COVID as well. When we look at the sepsis guidelines in COVID says that you resuscitate patients, but err towards the drier side. That means err towards the lower volume. Now, this is a very difficult or it's a very controversial, ambiguous statement. In sepsis guidelines, they have said give 30 ml per kg to everybody who has come with sepsis. And we all know that we cannot give 30 ml per kg. It may be that while resuscitating, you have given 2 liters of fluid to somebody and it happens to become 30 ml per kg, but we never aim to give 30 ml per kg. And the reason is because you have already shown in your first case somebody with ESRD and sepsis. How do you know you'll give 30 ml per kg, right? So you need better assessment tools to figure out how much fluid is essential. The same thing is happening in this child. I mean, this child will obviously need a lot of fluid volume loading. How much? After the initial volume load of, I think, maybe 6 to 8 ml per kg volume loading, you will need some sort of advanced monitoring, some sort of advanced technique to tell me how much more fluid this patient can take in. Also, we need to check the extreme vasodilatation from which this child is suffering, which is also another pathogenesis of viral sepsis. And we will need to start vasoactive drugs earlier along with volume loading. So, and we also need to curb the inflammatory cascade. We all know that steroids now have been approved for COVID. So low dose steroids, not high dose steroids. Again, steroid stewardship is very, very important. We've seen patients coming to us with very high dose steroids, and that has created a havoc of secondary infections, mucor, etc., etc. We need low dose steroids. And whether there is a role of other immunomodulators in the form of JAK inhibitors and tocilizumabs is something that we can discuss, but probably not in this forum. So that's all I want to say for now.
Okay, thank you so much, Dr. Chandrashekh. So he has covered it well, and he has informed and he has given it a very clear statement that yes, COVID with sepsis or sepsis and COVID leads little bit of consideration and some changes. So my next question is to Dr. Aviral regarding sepsis management in a fluid overload patient, maybe in a CLD or CKD, as a case scenario was showing, a first case.
Hello, hi. So, wonderful. First of all, thank you so much, everyone, to be a part of such an esteemed panel. So, fluid management in septic shock, and what do you do with fluids? Suppose now this patient that we had in the first case, right? Suppose you're in a small hospital in, let us say, rural Bengal. The nearest tertiary care center is 3 hours away. All that they possibly have is maybe a mobile X-ray unit, and that's about it. What do you do in such a situation? And that is where we deliver 80 to 90% of our care. And we must understand that a majority of our care, and the reason that the severe sepsis and septic shock guidelines were written and the surviving sepsis is not for us. It is really not meant for the large tertiary care institution located in a major city that is catering healthcare, has super specialists or subspecialists of every kind that you can imagine at their disposal. It is meant for the rural center that is severely resource limited and has to deliver care, and it's meant for the masses. So, which comes down, what do we do with fluids? Fluids are good, fluids are not so good. It's just like everything else. You give too much fluid, you're going to overload your patient, and they have secondary effects of fluid overload. You have pulmonary edema, you have renal edema, you have diffuse vascular leak, and you're just going to struggle with the prolonged effects of fluid that happen later on, which are multiple studies to show that. In fact, there are multiple studies over here, like we have, that association of high dose fluid resuscitation is actually associated with worse outcomes. But if you actually look at the subgroup analysis on these studies, when did they get these fluids? Getting fluids up front has rarely been associated with poor outcomes. It's usually later on in the second half of their illness for patients who are persistently getting fluids repeatedly that usually do have worse outcomes. You're also running into a chicken and the egg situation, that are they getting more fluids because they're worse, or are they getting more fluids because we're giving them more fluids? Remember, the persistently hypotensive patient is going to get far more fluid than the patient who's actually volume responsive. So is the fact that they're volume responsive an indicator of slightly milder disease phenotype than the person who, even despite getting 30 mLs per kg fluid, or 3 liters of fluid early on, continues to be hypotensive? So that's what it comes down to. We have a study over here saying fluid resuscitation patients end-stage kidney disease. And they identified patients where, this is based out of New York, and they identified patients with end-stage kidney disease who received 30 cc's of IV fluid and those who did not receive 30 cc's per kg of IV fluid. And there was no significant difference in the two groups on rate of intubation. But what you will change is the rate at which you give those fluids. In fact, I do believe we have a slide where it says, it never says you have to complete fluid resuscitation within the first hour. It says you have to begin fluid resuscitation in the first hour of severe sepsis management. Start giving your fluids. There is no need to finish them fast. Give your first liter. If it's a renal patient, if it's a heart patient, if it's a liver patient, maybe don't give 1 liter, maybe give 500 cc's, see how they're doing. Okay, they're doing fine, give 500 more. Are they okay? Give 500 more. Nowhere does it say that the 30 cc's, giving the 30 cc's per kg is actually harmful to the patient. Even if you see Paul Marrick's study where they did a premier database analysis out of 2013, it's when they start talking about cases like more than 5 liters and above is starting to cause negative outcomes. Nobody gives 5 liters within the first day or as a part of initial sepsis resuscitation, at least in the first few hours. So we have to identify first we have to get rid of fear. I keep saying this, it's almost like critical care or the ER physicians more clearly, since this is more of an emergency department. This is the emergency department's ambit. It's almost like they have hydrophobia when somebody walks in with, it's like the Indian doctor, like a colleague of mine, Dr. Chandrashish knows him very well, keeps saying, Indian emergency physicians have rabies. Like they're all hydrophobic. Like somebody walks in with end-stage kidney disease, somebody walks in with end-stage liver disease or CHF, and God forbid you have a combination of those two, is like, you're not getting fluid. I'm sorry, they'd rather put you on vasopressors and send you up than get fluid. And it just comes down to understanding pathophysiology. Let's think about a heart failure patient. They are used to living at filling pressures of supranormal filling pressures, right? You and I, we might have a left ventricular end diastolic pressure of 4, 5, 6. They probably have of 10 to 12. Now, if they are septic and they're living at 4, 5, 6, they're actually hypovolemic to the point that not are they in hypovolemic shock, they're also probably in cardiogenic shock as well because of reduced filling pressures. Now, you're going to say, oh, we're not going to give this person fluids that got filling pressures of 4, 5, 6. No, the concept is you got to fill them back to their normal. And that is what the surviving sepsis guidelines, or for that matter, this guidelines basically say. Bring them back to where they usually live. 30 cc's per kg has not shown any negative data associated with that. There's no increased rate of intubation. There's no increased rate of mortality. And in fact, there's decreased rate of mortality. So in my mind, be careful with how you apply the guideline. But if you're in the masses, if you're in the rural areas, you will never go wrong in maybe giving a little bit of extra fluid. You're worried that they'll need intubation? Nope. End-stage kidney disease did not need high rates of intubation. Are you worried that they might have your heart failure patients might have increased mortality, increased intubation? Nope, they don't. They have the same rates of intubation when they got 30 cc's per kg as compared to when they got a restrictive strategy.
Thank you, Dr. Viral. So if I just give you one statement, say you need to resuscitate, you need to give fluid boluses, but maybe you need to monitor them well and you need to see how much is necessary. Not necessarily it has to be 30 ml per kg body weight. It has to be assessed, individualized, right?
Yeah.
Okay, thank you so much. So after this scenario, let us move to another condition where maybe the things, again, the sepsis guidelines, following sepsis guidelines strictly may be a little bit detrimental. So for this, I would like to ask, or I would like to invite Dr. Mohit Kharbanda to please speak on the topic sepsis in pregnancy. Dr. Mohit?
Yeah, hi, good evening. Happy to be here with you all. So couple of things I would like to mention in the start. One is that as we are doing this Sepsis Day program, so the main purpose of the Sepsis Day program, of course, is to increase the awareness amongst people who are not usually dealing with sepsis day in and day out. It's not, this program is probably not for the, as Aviral also mentioned, it's not for, say, tertiary care setups in the bigger cities. So similarly, the surviving sepsis guidelines have also been designed in such a way that you serve to, basically create a basic platform to which all of us can sort of adhere. And I sort of call it I tell it to my juniors that surviving sepsis guideline is like the Gita of critical care. That if you follow those type of protocols in all your patients, then you probably won't go wrong. You are not likely to cause any harm to your patients if you follow the the thought process behind the surviving sepsis guidelines. Of course, the patient-to-patient variation will be there. Every patient is different, and patient-to-patient variation will be there, and you need to modify the guidelines according to the scenario. But if you basically follow the basic dictum underneath that you give, when a patient comes with sepsis, you need to do initial fluid resuscitation. When you're ventilating the patient, use a lower tidal volume. When you're using vasopressors. Maybe the first line vasopressor has to be NORAD. If you're getting a patient with sepsis, then say force control has to be there. So if you're following the basic tenets of the surviving sepsis guideline, then you're unlikely to go wrong somewhere. Of course, like in pregnancy, we need to modify the various things depending on the typical pathophysiology of pregnancy. So as we understand that the pathophysiology, the physiology of pregnant patients is different. They have definitely a higher output. It's a hyperdynamic state, and they have a higher respiratory rate. They have higher tidal volumes. They have a slightly respiratory alkalotic state, and they have a lower systemic vascular resistance. They have higher renal plasma flow, and it's also a prothrombotic state. So all those things have to be kept in mind while we are managing these patients in our ICU. So for example, if you are ventilating these patients, your target PCO2 has to be slightly lower. That way also, you have to target a PCO2 of around 30 to 32. You have to target a pH of 7.4 to 7.47. Again, it has also been shown that to prevent fetal hypoxia, maternal PO2 of at least 70 has to be maintained. You have to be careful while giving this sedation. Also, try to avoid the benzodiazepines. The opioids are okay. If you have to use the neuromuscular blockers, then maybe cisatracurium is the first choice. If you have to use the vasopressors, then noradrenaline is probably the first choice here also. But don't use vasopressin because that may cause decreased perfusion to the uterine vessels. If you have a patient with accelerated hypertension or preeclampsia, then maybe ividlabetalol is the agent of choice to treat accelerated hypertension. In these patients, if you are having seizures, patient with eclampsia, then maybe intravenous Maxulf is the best choice to with the bolus followed by maintenance to treat these patients. You need to always remember that the bulk of the uterus can compress the IVC and decrease the venous return to the heart. So always, if you're having a patient with decreased perfusion, try to keep a pillow under the hip, make the patient slightly lateral so that the venous return is improved. If you're going to intubate this patient, then it is very much possible that the patient may have airway edema, and the glottic opening may also be maybe smaller, and it may be difficult to intubate these patients. And there are again some typical diseases or typical disorders that are there with these patients, which you have to keep in mind while treating even common these. So they may get various, apart from the usual diseases that a normal person's get, there are certain diseases or disorders which are particular to pregnancy, like the fatty liver of pregnancy, or the tocolytic pulmonary edema, or the preeclampsia, or eclampsia, or the HELP syndrome. So, or the peripartum cardiomyopathy. So, whenever you are treating these patients, you need to remember these things also. Dr. Eshu.
Okay. Thank you so much, Dr. Mohit. So you have very well lightened up few important points in pregnancy and sepsis which have to be considered. So where maybe not necessarily, as I've shown, not necessarily we have to follow the guidelines strictly, and there may be some changes from the surviving sepsis guidelines. But yes, very truly said that surviving sepsis guidelines is sort of a Gita for all our critical care specialists. So the next syndrome or next case where the sepsis guidelines may fail or to follow is the dengue shock syndrome. For this, I have Dr. Saurabh Pole. He would be enlightening us on this topic. Dr. Pole. Dr. Pole, are you there?
Yeah.
Yeah, thank you. Please go ahead.
So thank you very much for inviting me to this program. And regarding dengue hemorrhagic fever, dengue shock syndrome, we all know that some patients with dengue fever go to develop dengue hemorrhagic fever, a severe and sometimes fatal forms of the disease. It usually happens initially after the 3 to 7 days after the symptom onset. The patient may develop warning signs of severe disease. Warning signs include, we all know, severe abdominal pain, persistent vomiting, mass change of temperature, and suddenly patient may come with the hemorrhage, manifestations of change in mental status, irritability, confusion, obtundation. And the patient also may have early signs of shock, including the restlessness, cold coming skin, rapid pulse, and most important is the narrowing of the pulse pressure. So DHF is we are following four. We know that the WHO has told that the 4 criteria: fever of recent history of fever lasting for 2 to 7 days, and any hemorrhagic manifestations, thrombocytopenia, and most important is the increased vascular permeability. So whenever we are thinking of this dengue with the dengue shock syndrome, and definitely, in fact, we are not following the sepsis guideline here. Then, whenever the patient is in if we go to the mechanism that whenever the patient is more serious type, chance of hemorrhage is there, including vaginal bleeding, hematemesis, melena, and intracranial bleeding. And plasma leakage may also happen. Evidence of plasma leakage due to an increased vascular permeability consisting of at least one of the criteria: increased hematocrit, if it is more than 20%, and if we can find presence of pleural effusion, ascites, etc., and anemia, and then we can think that it will be dengue shock. So dengue shock syndrome is defined as any of the whatever in the dengue fever, dengue hemorrhagic fever, and evidence of rapid weak pulse and narrow pulse pressure if it is less than 20 millimeter of mercury, and hypotension, restlessness, cold coming extremities, etc. So, in fact, found that in case of dengue shock syndrome, the fatality rate may be 10%, but if we can manage it properly, it may be less than 1%. So, regarding the management of this dengue shock syndrome, again, here the 3 is of immense importance, and there are so many studies where the different types of fluid also being used, crystalloid, colloids, lignal lactates, etc. And we use most likely crystalloids, but lignal lactates are also equally useful. And obviously, in case of the dengue shock syndrome, fluid transfusion is of immense importance. We have to see the other comorbidities, other heart conditions also. But in case of this dengue shock syndrome, this fluid is to be given in a high dose. It is to be given, say, 20 ml per kg for 1 hour, and if the patient improves, then we can make it 10 ml per kg for the next 4 hours. If the patient doesn't improve, then we'll have to give another 1 hour with the 20 ml per kg body weight. And if again it doesn't improve, we have to take the other efforts like the noradrenaline transfusion, etc. So regarding the sepsis guideline, I know that we are discussing very much about the de-escalations and the antibiotics, escalations of antibiotics, etc. But here, in case of this dengue shock, probably the use of antibiotic is only necessary when the patient is having super added infection. Otherwise, role of antibiotic is minimum in case of the dengue shock syndrome. In dengue shock syndrome, along with the fluids, other thing which is necessary that we may need platelet transfusion. If we may need the blood transfusion may be also necessary. And if the patient it doesn't improve, then in future we may, if the patient becomes oliguric, then we may need the renal replacement therapy, etc., etc. So what I mean to say that in case of dengue shock syndrome, the management with the dengue shock syndrome is different with the normal surviving sepsis guideline also. And whenever you are thinking of sepsis, primarily always it's in our back of the mind is the bacterial sepsis. But here you know that it's the it's a viral sepsis, and in that case we don't have such specific drug for the dengue also. So that's why we have to go for the supportive treatments, and we have to treat it accordingly.
Very rightly said, Dr. Pole. Thank you so much. So this is one of the conditions which mimic sepsis, as rightly said by Dr. Pole, and the management which differs from the protocolized, from the guidelines and the protocolized manner. So here I have just highlighted, or I have just highlighted few case scenarios or few case presentations which may mimic, and where maybe the proper following guidelines would be so easy or very rightly done. So I want to discuss this one topic which we have been discussing. Again, Dr. Sharmili also mentioned, and it has been also mentioned by Dr. Todi sir also, the usual care versus the protocolized care. So I would like to invite Dr. Shantanu to highlight us on this topic. Dr. Shantanu, are you there?
Yeah.
Okay,
thank you. Thank
Okay.
you for inviting me to this session. This is first of all, Dr. Kharvandas, that this is a platform, like any protocol is a platform. So now, like I'll give example of sepsis, surviving sepsis guideline. If it is a typical bacterial sepsis with shock, definitely it fits everything. Now, this giving antibiotic, 1 hour goal, second hour goal, glucose control, anotropes, these are all rough guidelines some has to follow because it gives a direction. If you don't obey the protocols, then you are not directed. You may mislead, you may do something harm to the patient. So protocol is like a platform. On that, some patients, like as you mentioned, chronic renal failure, hepatic failure, or both of them, or pancreatitis decay, these are the patients you need to deviate. But initially they need some resuscitation, whether it is 30 ml per kg, whether 20 ml per kg, depending on the situation. You have a bedside method, like you can see IVC, one of the best tool, I believe, bedside, that you can see, except few patients like portal hypertension, like your right heart failure. These are things you can mislead the IVC. You can say CBP. These are all rough guidelines. You can direct the fluid. But initial registration should be good, and mind it always there that these patients who are prone for overload, low albumin patients, patients with renal failure, patients with dilated cardiomyopathy or chronic heart dysfunction, these are the patients you need to remind that you have to resuscitate and control resuscitation. You have to check every time. There is a checklist for it. Like what is the IVC, what is the urine output, what is the vital, what are the, if you have a non-invasive monitoring, if you have something like an invasive monitoring, it will guide you, like SBB, you can have pulse pressure variation, so cardiac index, everything you have, if you have a monitoring, invasive monitoring for that. But the thing is, if you don't have a protocol, then who will guide you? What are the initial approach? How should you approach a patient when it comes with a sepsis? Whether it's a viral, whether it's a bacterial. Okay, you understand viral sepsis has something different pathology. Bacterial sepsis has got different pathology. Viral sepsis, though, like I'll give an example of dengue. Most of us has struggled with the inflammatory markers and the lung. It is a basically interstitial disease. Start with the interstitium. And probably all of you know, there is a 1 or 2 COVID postmortem in Italy. They have seen it's arterial clogging before hyperthrombosis or thrombotic phenomenon. And now also a lot of patients have died because of the inadequate anti-thrombotic agents after discharge. So there are different kind of pathology, but you still need to resuscitate the patient when there is required of volume. So protocol is definitely there, but you have to deviate in some patients, and it should be scientific. And the next day onwards, the first day is resistant, but next day onwards, you have to apply the clinical acumen, you have to apply your lab values, your NT-proBNPs, a daily echo, a lung chest X-ray, or an ultrasound of lung, like your B lines and all this will guide you to go for the resuscitation, how much fluid you need. Some patients I have seen, DCM patients we thought maybe the ejection fraction 30. We need less fluid, but we have ending almost in giving 3 liter, 4 liter fluid. In,
Dr. Rishu, we are running late. Dr.
Okay.
Rishu, we are running late.
Yes, we'll finish it in 2 minutes, sir. Give me 2 minutes.
So protocol is definitely there. It's a platform, and we should then deviate by initial approach. I think it will guide in initial approach. You can well direct it, and then you can deviate depending on the evidence, lab evidence, clinical evidence, and other invasive parameter evidence. So you can deviate on that, but definitely protocol will guide you in better way. The most important thing is you will not do any harm to the patient, like overloading the patient, giving antibiotic in the right time, sending culture in the right time. Like the previous patient in the slide, like he has a infected fistula. You need to resuscitate and find out whether there is a septic or any pus or any septic fistula. There, you need to give antibiotic in the right time, send culture in the right time. Then overall, you can see the TLC, procal and everything, whatever is there, escalation, de-escalation, whatever is there. So guideline is definitely a platform. On top of that, you can deviate. So guideline is required, but yes, usual resuscitation always can misguide you. That's what I feel.
Okay. Thank you, Dr. Shantanu. As Dr. Asif have already given us a ringing bell.
That's what I had to finish it quickly. I know.
So it always happens if we have the last discussion of the whole session.
It's like vegetarian they suffer, right? Yeah, I know.
True.
And Dr. Asif, thank you.
Without much delay. Thank you so much all the panelists.
Risu, I'm giving another 2 minutes if you have any question, anything.
So I just wanted to have some concluding remarks from our esteemed panelists, if they would like to remark at the end something. Few things which will be the take-home message will be, yes, guidelines are there as a Gita. We need to know the guidelines very well, but we should also know where to place, where to follow, and where maybe we have to be cautious. As per the monitoring part, we have nowadays the non-invasive monitors, which, for example, ultrasound, as Dr. Shantanu have mentioned very well, the ultrasound is not only used as only a diagnostic tool, but in fact has been used on a day-to-day basis for a therapeutic purpose also, by guiding us how we are going towards a treatment part. Anything else, our esteemed panelists, would you like to add or comment? We have just 1 minute more and then we'll conclude.
So, I will ask Dr. One by one, all panelists, for a concluding statement for this sepsis mimic. So, first I will start with Dr. Oviral. Your conclusion statement for this session.
Hi. So thank you so much. So I just like to conclude by saying severe sepsis, septic shock is a catastrophe. It is to be treated with the same urgency and responsibility, the same way you treat a myocardial infarction or a stroke. Time is of the essence. We reduced it down to 1 hour because that is the golden hour, whether it's trauma, heart attack, and now sepsis. Treat it with the same urgency. Resuscitate your patient. Yes, if they are highly likely to get into a fluid overload state, be more vigilant, but that does not mean do not treat them. Having comorbidities does not mean do not treat. It means be more careful with your treating.
Thank you.
And
Dr. Saurabh, your conclusion remarks? You are muted.
You're muted. You're muted.
I am just doing the word of Dr. Oviral that that in our state, definitely critical care is spreading to the different parts of the different districts. So what he had said rightly, that the first 1 hour is of equally important, is of immense importance. So whenever the patient is sepsis, if he is thinking to go to a better hospital, it may be say 60 kilometers away from that place, it will be much better if this knowledge can reach to the peripheral ICU, peripheral critical care units, so that the patients can also be benefited and the doctors also can be engaged in this program.
Dr.
So I would suggest that in future, I would suggest
yeah, I would like to say that while treating sepsis, do also remember the sepsis mimics, that sometimes we overemphasize on the white counts and CRPs and procals and over treat a presumed sepsis with antibiotics. So a lot of conditions may be there which are not actually sepsis, they are sepsis mimics, and they may present like sepsis. For example, the MISA that has come up recently. So don't miss out those while treating sepsis. A lot of autoimmune disorders, a lot of other things can be there which can present like sepsis, though don't get blinded by the sepsis only. Please look out for the sepsis mimics also.
Thank you. Dr. Chandrasis?
Chandrasis, Dr. Chandrasis, I think he is left.
Okay. So, Dr. Shantanu Das?
Yeah, as per the protocol and non-protocol treatment is concerned, as I told, you need a protocol. On top of that, you can deviate and use the clinical judgment tools, lab values. So don't always be flowed by only septic shock and all. There are many conditions which can mimic like sepsis, but then you do not need entirely septic surviving sepsis guideline. So use tools if you possible in your hospital like ultrasound, invasive monitoring. Take help of the other consultant if you are not able to find the cause in respective department organs. So I think protocol is needed, but you need to be very careful that something can mimic the sepsis, and use the tools, use the protocol, but wisely, and use the clinical equipment.
Dr. Reshu here.
So that's what. First of all, thank you, Dr. Asif, for giving me this extra 2 minutes to get a concluding remarks from my esteemed panelists. We had this discussion and we have been discussing for the last 3 days continuously regarding this topic. So yes, as rightly said and mentioned, that we have to follow and we should know the surviving sepsis guidelines, the protocol, but we should also know where to use and how to use. That is very, very important in a monitored way. We should not be blinded and we should not just go with a fixed protocol for each and every patient.
Thank you. Thank you, Rishabh. And I will request Farz Academy, please share the vote of thanks slides. Thank you, Rishabh. It's a wonderful session and you have done great job.
At least I could cover up your time. That's what I know.
It's such a things that it is not very easy to conclude in the half an hour time. Sepsis is a vast subject.
All the subjects were controversial, of course.
Yes, a lot of things is controversial. That's why I've given Risu and first day she called me and say what to say.
She did marvelous.
Yeah.
Thank you so much. Thank you so much.
Thank you for your effort. It's really nice presentation.
No, I think I should thank you and all my panelists. We have done a teamwork, as the critical care team always says. It's always a teamwork. It's never individualized, right?
Under your leadership. Under your leadership.
No.
Yeah. So thank you, and I will thanks to the Indian Society of Critical Care and Farz Academy. They both have initiated this meeting for in this occasion, World Sepsis Day. And also I will thank you to CIPLA Critical Care, Abbott Critical Care and Abbott Nutrition, and also Mylan Pharmaceutical for their support to help to organize this meeting. And I will thanks to all the participants and all faculties. They devote time and they come and they made the successful the program. And thank you ICCM, long life ICCM. Saurabh, want to say something? I think.
No, it's fine. It's fine. Very well organized program, and it's obviously the day is also equally important. And in this important day, with such a good number of speakers are here, I think it's a very wonderful program.
Yes, congratulations, Dr. Yusuf. Absolutely wonderful. And it was really nice to be here, to be part of this program.
Thank you. Thank you.
Thank you, everyone. Thank you.
Thank you, everyone.
Thank you. Assalamu